Yes,
on the top, maybe?
Yeah, we sent her message.
Oh, okay.
All right.
Ah, look at it.
Hello. Hello, everyone. Hi, everybody. I have you guys unmuted at the moment, but what I'm going to do here in just a second is I'm going to remute you. So if you should need to speak, if you will send a message in the chat for us, and we will try to answer there. What we're going to do is Dr. Uhlig is going to start. We see Dr. Eng is actually on the system, but she may not be at her computer. And then Dr. Uhlig is going to share some information around PTEN and the immune system, information that he knows to date, and what we need to do to take best care of ourselves. And then Dr. Eng is going to chime in, and hopefully she will be on the system in a moment, and she will speak with us as well. I'm going to go ahead and mute everybody, and with that, I will introduce Dr. Uhlig. And Dr. Uhlig, I will let you share just a little bit about yourself and what you do, and we greatly appreciate your time and speaking with us today.
thank you.
Thank you.
Thank you, Christine, for the invitation, and I'm most grateful to speak to you all, because I'm a pediatric gastroenterologist, so I see children with immune problems and with polyps here in Oxford, in the UK, and in London. And I have been over the last few weeks on the phone with many families who have rare diseases, who have problems with PTEN, and other immune problems, immunodeficiencies. And the overarching worry, of course, is what does this virus? Is this Charis?
Hello, everyone. Please mute upon entry when you enter the chat.
Virus do to us? What is the baseline risk? As is of course sort of already sort of a worry, but then in addition, of course, what does it do if patients have weak immune system, some immunodeficiency, some overreacting immune system in terms of some autoimmune diseases? What happens if they take medication? What happens if patients have tumors and have anti-tumor medication that either weakens the immune system or makes the immune system stronger? And obviously there are major differences between adult patients and pediatric patients. So just as a very short sort of summary, as you all know, and I think you all follow probably sort of daily sort of the news that are quite shocking. There is this virus that started, as we think, in November or December in Asia, and then sort of spread throughout the world. That has been for quite a while sort of maintained and probably quite well managed in China, but nevertheless sort of spread out, and it needs very harsh methods to maintain the virus. And of course, throughout the world, hundreds of thousands of people are not only infected, but became sick, and tens of thousands have died throughout the world. So what we do know is that the main infectious disease is a virus. It spreads relatively fast, and people become sick, usually of pulmonary problem with the lung. there is an overarching immune response, and some people, if they have the disease over 10 days and with high fever, then really get sick and need respiratory support there. It's largely a disease of older people, and older starts with 50, 60, but largely 70 and 80 years of age. And another risk factor are additional diseases, in particular lung diseases, diabetes, and comorbidity in the heart. Males are a bit more affected and have more severe disease. And we are currently, I must say, sort of very shocked about the degree of the disease. Obviously, in the US, you see it every day. Sort of what happens in New York and in other big cities. And on the other hand, we are a bit glad that at least sort of the children and the youngest ones are much less affected by this disease. Nevertheless, of course, patients and their families are very scared and ask about the advice. And currently, we know for diseases like PTEN very, very little what does happen. So we can largely give general advice, and the general advice relates to the age and to the risk factors. So if there is a patient over 60 years of age, then the risk is starting, and then sort of social distancing, trying to avoid any chance for an infection should be taken. There are some countries who have very, very strict rules, in particular here in Europe. Some states in the US have adopted to this, but not. My understanding is not every region has done so. But this sort of is probably sort of the most effective way as a population to reduce this risk and to reduce that the healthcare system becomes overwhelmed. Individually, the most important thing is to avoid infection, and this is by avoiding contacts and avoiding larger crowds, washing hands, trying sort of to have less risky an environment. And in particular, of course, if you take medications of anti-tumor medication or medications that boost the immune system, like checkpoint inhibitors that some of you will take and experience. So that's an overview. Christine, is there anything that you want to raise, or any specific questions?
I think you briefly touched on it, but I know we have some patients that are on everolimus, and they wonder if that affects them differently, being on the everolimus medication. Does that make them any more or any less at risk? And I know there's some studies or school of thought, which is less understood, that perhaps it might even be a good thing if they're on this medication. Can you touch on that a little bit?
So, Kristen, it's Charis. Can you hear me?
Hi, Charis.
Yes, Dr. Eng.
Okay.
How are you?
Good. How are you? Sorry, I struggled to get in, and then I said, let's just use the phone. So apologies, I am on the phone.
No problem. I'm on my phone as well.
Okay.
So, Doctor,
why don't I take that question, and then Holm can jump in. So I've heard everything, seen everything. I just couldn't get in.
Okay, no problem.
Okay, so one of the purported, and I said purported, treatments for COVID-19 serious disease is in fact mTOR inhibitors, such as everolimus. So of course, as physicians and scientists, we have to say there is no proof in that disease, but I don't think it's anything to stop. So that's on one hand. On the other hand, as you know, some people do have immune suppression from viral illness, and if that's true, then one has to say that perhaps that person is more susceptible. So I'd love to hear what the immunologist thinks.
Yeah, I think it's a double-sided sword. That is, yeah, I completely agree with you, Charis. So there are, so we do know that adult patients with immunosuppression might be more at risk for having the virus and other viruses. We know that I think there have been fatal outcomes. Also, the risk might be not as big as feared. But on the other hand, in pediatrics, we have some data that people who are under immunosuppressive medication have not become ill, although they have been infected. And because part of this disease is an overreacting immune system, it might be that indeed in children, it might prevent a more severe disease. However, to my knowledge, there is no good data set to suggest that whether the overall net effect is positive or negative. What we say to most patients is currently to maintain the medication, because some medications are very important, and if you stop them, you might be at higher risk than compared with the virus.
Absolutely. Dr. Eng, I know a lot of our families have asked questions about what they should do to protect themselves, and Dr. Uhlig touched on this briefly, but are they any more or any less at risk of contracting COVID-19 having simply a PTEN mutation?
The right answer, of course, is that we don't know, because there has been no research and no experience, thank God. But for some of you who have reached out to me individually via email, I've been telling people to behave as though people with PTEN mutation behave as though you have chronic disease. So be a little bit more cautious and behave as though you could be, in fact, that person with diabetes. And just, you know, listen and follow the directions of the state and local authorities. So the CDC has guidelines, and each state is different. So each state, in theory, should be at least as strict as the CDC guidelines, but each state and local authority can be stricter. They shouldn't be less strict, because I think that's not a good thing. And so you've heard the guidelines of avoid social gatherings in groups of more than 10 people. Social distancing, at least 6 feet. Hand washing with soap is the best. Second best, alcohol-based hand sanitizers, right? And clean and disinfect frequently touched objects and surfaces. And sometimes you don't think of that doorknob, right? That doorknob to go into the bathroom, public bathroom. I mean, you have to wash your hands before you go and after you go. I know that the CDC is suggesting, not mandating, using face masks, but my pulmonary and critical care physician friends say that it doesn't really help. Use a face mask if you're sick, and by sick, I don't just mean the coughing and all that and having a fever. Usually right before you're sick, called the prodrome, is when you are the most infectious. And so you're actually wearing a face mask, not necessarily to protect yourself, it's to protect others. Be mindful of materials also that either sustain the virus for hours or for days. And so things like cardboard, tissue, paper, once the virus is in there and it's dry, it's dehydrated, it's gone. Whereas leather is the worst. It can stay there for 9 hours or even a couple of days. Yeah, I think social distancing and staying at home, sheltering in sight is the key. So then let me give you some real data from the Cleveland Clinic. So we were one of the first in Ohio. In fact, we were the first non-Ohio Department of Health lab that the pathology lab tests for COVID-19. So in the beginning, people who have flu-like symptoms were offered this testing. And in the beginning, 20% of all those, so remember this is early March, 20% had influenza A. Of course, the flu was going around. 3% had COVID-19. After the shelter-at-home order, there is 0% influenza A. And so this speaks that the shelter-at-home actually works. Are you all there?
Yes,
Here
sorry,
we go.
can you
Okay.
hear me?
Yep.
We appreciate that, that answer. I have a very interesting question that came from one of our Canadian patients, and she specifically asked, would a vaccine for COVID-19 affect PTEN patients differently, that is when one is developed, because of our immune issues, or would it be protected as much as the general population? And then the second part of that question, should we keep social distancing measures, all that you just mentioned, as long as there's no vaccine available? So I've heard as much as 12 months. Or if our respective communities say perhaps in May, or I don't know, for some June, that is when we can get back to our normal lives. Can we do that?
No.
Or should we social distance?
No is the short answer. So if we are socially distancing, right, called mitigation. So social distancing, masks, if some of you want that, not gathering in crowds, goes under the term of mitigation. So mitigation works by flattening the curve, but pushing the peak out. If mitigation is not used, as in Italy, it's a very, very early peak. So with mitigation in the US, so it's somewhere between mitigation 100% who follow it, and you know in the US that's not true. So let's say there's partial following of the mitigation. The peak of COVID-19 is predicted to be somewhere between mid-May and early June. And that's the peak. It's going to get worse before it gets better. There'll be more cases, there'll be more deaths, I'm afraid. I would say usually 6 weeks or more after the peak is probably when it's the all clear. Most public health people will say they want to see 14 days of no new COVID-19 cases before they sound the all clear. So if you're in doubt, socially distance and use common sense is what I always say.
I could add on to this first question on the vaccine part. So the vaccine is, of course, a big hope that would be there. And there are two types of vaccines. So one is called passive vaccine, and the other one is an active vaccine. So for the future, I think the aim would be to have an active vaccine, so something that mimics the virus, and then the patient's or a person's immune system is responding, building antibodies, and these antibodies will then protect from future infections. And a lot of companies, a lot of research groups work on this. It's not a very simple thing. It can be obtained, but it's probably very, very heavily sort of researched upon. And for the vast majority of patients with PTEN, we would not expect that the immune response will be any different to the immune response to any other healthy person without an PTEN mutation. There might be subgroups, a small fraction, where there are low lymphocytes, low immune cells, and low immunoglobulins, and in this subgroup, the immune response might be less. But I think for the vast majority of patients, all the studies that we have done, and we have done jointly with Charis and others, would suggest that the immune response is skewed, but still sufficient to drive a protective response. But that's just a projection. For the passive vaccine, I think there are studies ongoing, twofold. One that is using the plasma of patients who have recovered. And for some regions, some hospitals have some encouraging data that for the worst affected, those who are really in intensive care, who need respiratory support, this immune response in the plasma of somebody who has been undergone an infection, who has mounted an immune response, could be helpful. And this could suggest that a gene technology produced serum that contains the anti-coronavirus antibodies could be helpful as a safer and more applicable solution. And I'm pretty sure this would probably be the next step that is coming before the active vaccine. And there has been quite a bit of progress, because these coronavirus infections have happened before. There were outbreaks that were called SARS and MERS, and people have researched in these instances, and it seems that some of the immune responses and some of the antibodies that have been generated in these previous outbreaks from independent viruses, they seem to be cross-reactive. And so there is a hope that by learning from these previous outbreaks, and passive vaccine could be produced. But it's two ways. It's active and passive, and both might be helpful. But on a big population side, it will be these active vaccinations that holds the most hope.
Dr. Eng, did you want to add anything to that? The comments from Dr. Uhlig?
No, I think that's absolutely right. And it's not new, drawing plasma from patients who have convalesced from viruses, through the ages. This is what you give to people who are dreadfully sick, where there's no medication yet. And I say yet because there are many clinical trials ongoing and no active vaccination yet. And the reason why you hear the 9 months to a year is that it has got to go through the trials, and then it has to go through FDA approval.
I got it. Dr. Eng, I just had a question from one of our patients who said, when is it safe for us to come back to Cleveland for our regular doctor visits?
Yeah, so right now our institution is suggesting July 15th. And I know that we've told some of our patients it could be as early as June 15th, but we've also been hedging to say, please, can you be flexible? And of course, it depends when that peak is. When the peak occurs, I think will be much more accurate. So again, mid-July is assuming that the peak is in mid-May.
Okay, fantastic. Are you at the Cleveland Clinic, or Dr. Uhlig, for you in the UK, are you doing online visits or video visits with patients who have a need to try to keep that continuity of care? Dr. Eng, I'll let you go first.
Oh, yes. No, we are, but here's the problem. I am only licensed in Ohio and Massachusetts. And so there was an Ohio person probably this Thursday where we are going to do a televisit, telegenetics, and we have used telegenetics for a long time, since 2013, but it's that licensing. Now, you would think in a crisis like that the governors would waive it. So some states are beginning to waive this. So I understand that Indiana has waived it. So if someone's in Indiana, I certainly could call in. But then, of course, so our PTEN team also are very happy to see people via telehealth portal, and you can imagine that dermatology actually works very well. It's probably even better than seeing on site because there's light and there's magnification. But you can imagine that you're here to see Dr. Buck for your routine colonoscopy, and unfortunately that cannot be done virtually. I mean, I wish it could, because then the prep doesn't exist.
Right. Dr. Eng, I don't know if you can see, we're getting a few good questions, and please just give us a heads up when you have to get off, or you, Dr. Uhlig, as well. One question from one of our patients: is it thought that the passive route would be preventative as well, or only after infection? We might need clarification on that, maybe, unless you understand the point there, Dr. Eng.
No, I think let the immunology expert speak to that one.
Okay.
Holm, you're on.
The passive route, in theory, I mean, this has not been proven. This we only can make assumptions from previous views and previous viruses, and the half-life is about 4 or 5 weeks. So for a short term, it can offer some protection. This is what nature does. Every baby gets some antibodies from its mom via the umbilical cord, and then we do know that this offers protection for 4 to up to 12 weeks when it's gone. So if there is some passive vaccination, it could potentially for a few weeks offer protection, but it will not be cheap. It will not be the general route to go, and it's not yet approved. So nobody would give plasma just as a prevention in the moment. It's really reserved for the ones who are most severely affected. Because obviously with current approaches, with plasma, there is a certain infection risk as well. It's never zero. There is a certain risk for adverse responses, for allergic responses. And until we have a proven, FDA-approved, clinical trial-approved active or passive vaccine, it will take months or even years. So this is all just in the trial setting.
Okay, we have another question, which is a really good one, and I think you briefly touched on this earlier, Dr. Uhlig, and she says, I have a child who has gotten ill from vaccines which were live, chickenpox, meningitis. His IgA levels are extremely low, which I think we find that with quite a few of our patients. Would a vaccine, a potential vaccine, I think she's asking, be safe for him? Or only, I imagine she's asking if it's not a live vaccine.
Yeah, and this is exactly the point. So if the immune response is low, then having non-live vaccines would be the recommended way. And this, of course, for coronavirus is purely speculation, because there is no vaccine, neither an active nor an or live and or non-live, nor there is an approved passive one yet. So yes, if there is a confirmed immunodeficiency or previous vaccine responses to live vaccines, one would recommend to have a non-live vaccination.
Okay, thank you. Dr. Eng, I believe this would be a question for you. What would be the suggestion for going to get labs or other options? For example, following up on slightly abnormal thyroids at this point in time. Would you hold on that, or would you try to do that with a particular lab that had safe practices? Dr. Eng, are you there?
Sorry, I muted myself.
Oh, no.
So all labs will say they're safe practices naturally, but what you don't want to do is to sit in this large waiting room, waiting with everyone else, waiting to get your blood drawn. So if it's just slightly abnormal and it's a matter of waiting 3 more months, which I think, knock on wood, it should be all over by then, I think it's okay to wait. If you can go into a lab where there is no waiting, you're just in and out, then that's what you want. And the other thing I should say is that it's not been shared publicly, and of course I know why, but you actually have to be within 4 feet of an infected person for 20 minutes or more to have an infection. So just passing someone COVID-19 does not do it.
Well, that's encouraging. I think a lot of us are scared because we heard you can have a conversation and actually pass the virus. But what I'm hearing you say is you need to be in close contact or close proximity with that person to actually catch the virus. Am I hearing you correctly?
That's why, yep. That's why it's the 6 feet, because just to be very cautious, so you have to be less than 6 feet for more than 20 minutes. And the reason why they're not saying a lot of that is because when people speak and you're close, they spit at you, right? Because you're spitting when you're talking, and it's the spit. It's not the, you're passing each other like two ships in the night and just waving and saying hello. You are not going to catch COVID-19 or anything else like that.
Okay, thank you. I have another question here, which is a good one. Our daughter is on weekly Hizintra immunoglobulin treatment. Should we expect antibodies to become present in the near future? Maybe Dr. Uhlig?
Can you?
So it's IVIG treatment, I believe. And she's asking, the mom is asking about antibodies via this treatment, additional antibodies.
Well, yeah, no, it's I just sort of, so the answer is potentially yes. So potentially yes, because at some stage, of course, because it's an these are pooled immunoglobulins. At some stage, there will be antibodies that will be transferred. So it's an excellent question. However, this process takes a while, and I don't think currently there will be sort of there will be much production there. So I think everybody would be extremely keen in not having, of course, sort of donors who might have the disease, although the risk seems to be incredibly low, and replicating viruses have not been found in the blood. However, of course, everybody's just anxious that there could be sort of some contamination. On the long run, of course, there will be antibodies, and these antibodies will go into these collections, but this is probably sort of half a year ahead.
Thank you. Here's another good question. Are the immune system issues for PTEN patients limited to patients on trials of new drugs or general issues overall? And I'm going to let you talk about this, Dr. Uhlig. I wasn't aware. If so, am I concerned this aspect might be falling between the cracks for us? My 11-year-old son has a PTEN mutation treated in the UK at Gosh by general surgery. lipomas, gastro issues, and other thyroid surveillance. So this question is kind of coming back to the point, do PTEN patients have immune issues, or is it strictly limited to those on immune-reducing drugs?
So if you are seen in Great Ormond Street Hospital, then we could offer you to that you could come jointly when you come to your next appointment to our gastro and immune clinic as well. I have a clinic jointly there, and we could surely arrange that you are seen, that you don't have to come twice. So what we currently think is that patients with PTEN as a group have a measurable effect on their immune system in the ways that they have a reduced number of white blood cells that are called lymphocytes, and that are important for the immune system. There is a change in their distribution of the cells, but it's only a very tiny fraction. And I think it might be 1% or 2% or 3% who really sort of have a significant immune issue, that they have very severe infections, repeat infections, invasive infections. For the majority, this measurable, what we call significant reduction in their immune response is probably still sufficient to mount a protective immune response. And on the converse, because in the immune system there is a double-edged sword, it's not just an immune deficiency. Immunodeficiency can drive autoimmune processes, and these can contribute to PTEN-related problems as well. So I think there is an increased immune response, and some patients have some autoimmune response as well. And everything we know so far, but the data are sort of not sufficient to make sort of a final decision, is that the ones with autoimmune responses do not have over-responding immune system to viruses as well. So I think if you have less of immune responses and immune deficiency, this very small fraction might really be at risk for infections. But the ones who have autoimmune problems, and this can be thyroiditis, can be diabetes, can be celiac disease, or even gut problems, probably still mount a normal response to bacteria and to viruses.
I would second that. I would agree with that. May I just maybe ask a question, make a couple of comments, sort of in general. So in general, and those of you who are my patients have heard me say that probably over and over again. So in general, an 11-year-old with lipomas, unless the lipomas are threatening a vital organ or causing severe pain, usually I tell my patients, leave it alone, because once it's removed, it will come back with vengeance, and you don't want to go down that slippery slope. The second thing that, again, I tell everyone in general, and it's been published, is that unless an 11-year-old has GI symptoms, bleeding from below, or just, abdominal pain, that you do a CAT scan and you don't see anything, does not need pill endoscopy, does not need colonoscopy until much later. So this is where, yes, we want to surveillance our patients appropriately. We don't want to over-medicalize them.
Absolutely, and I think this, I just felt sort of this was sort of, I fully agree with Charis, but this is very difficult for the individual patient to discuss here at the phone. But it's a balance of being cautious and not to over medicalize, of course.
Absolutely. and this is why we have care guidelines. And Dr. Eng, I think it's okay to say, correct me if I'm wrong, that you're helping lead an initiative to try to have academically agreed upon care guidelines worldwide so that we can make sure that our patients get proper care, not too much, not too little, exactly to your point. So,
exactly right.
And look for that for everybody on the call in the future when we get through this pandemic crisis. We only have a couple minutes, so Dr. Eng, I have a patient, and this would be for a offline discussion, but she's very worried her daughter's ANA titers, she's saying it's homogeneous, and she was referred to a rheumatologist, the only pediatric rheumatologist in the New Orleans area, and I know that you've heard what's going on in New Orleans right now.
Oh, yeah, yeah.
She wanted to know, and I can connect with you offline, if there is a physician who can see them via video chat from the Cleveland area to discuss this further, because she's very worried about her child. Okay, so I will, for that mom, I will get you connected. And we'll take maybe just a couple more questions if that's okay, and then we'll wrap up. Mom,
Kristen, would you like me? So I think what Holm was saying just now is that we cannot practice individual medicine here, and I'm not, and neither is he. And what we're talking about is either in the public domain or things that are in the guidelines and what is published, like with lipomas and the GI. I mean, it's been published. And so now, would you like to hear published research from one of my faculty members, Dr. Charis Eng? What he does is he uses big data and all the things that are known about COVID-19 or coronaviruses like SARS and MERS that you heard about, and he looks for drugs that are FDA approved that can be repurposed. Would you like to hear a little bit about that?
Absolutely, yes.
Okay, so Dr. Cheng has done all that, and there is a whole list of drugs, all of which are not over the counter except for one, and that is called melatonin. And people take melatonin for their sleep. So let me share with you the mechanism, and Holm can certainly jump in because obviously he's an immunologist. So people people know that the COVID-19 virus binds to TMRSS, so another protein, and then it via its spike, so the virus has a spike protein called S protein that binds another protein called TMRSS, and the two together, so the two have to be together to bind our own, the human being's ACE receptor. So ACE, angiotensin converting enzyme, is relevant to the control of blood pressure. So it is believed that our own receptors are the ones that facilitate the entry of the virus into us and through the blood vessels, and that's how they make us sick. What does melatonin do? So melatonin raises ACE levels, ACE2 levels, and when ACE2 is combined with its own receptor, it blocks the binding of the virus. So in a sense, is this a prophylactic? So now I'm making an extrapolation. So I'll share with you what's published. I've given you an extrapolation. So let me then tell you a few facts, and these are scientific facts that have been published. It's in the public domain. Elderly people have a decreasing ACE2 expression levels, and it is believed that it is because of decreasing melatonin. So we all know that as people grow old, older adults, I don't need sleep, I can't sleep, and so on. This is consistent with the observation, and you heard it from Holm earlier, that older adults are at high risk for the virus and a high risk of death. Whereas young children over the age of 1 have extremely high melatonin. They sleep easily, they sleep a lot. And so the ACE2 levels are higher, and one school of thought believes that this is how kids escape from severe infection. Kids under the age of 1, of course, don't quite have an immune system yet, and that's why the deaths in infants are always under 1. Melatonin is over the counter. In general, there are no side effects, and so I thought I'd share that.
Thank you. I think everybody caught that online. So melatonin is not a bad thing as long as you follow the instructions on the label. Correct, Dr.
Right.
Eng?
Correct, and always start low.
Start on the lower side. So thank you. That's incredible. Well, we are at the 11 o'clock Central Time, so we probably need to wrap up. There's just one question regarding the melatonin, and then we will stop there. We really appreciate both you and Dr. Eng and Dr. Uhlig for taking your time for our community. It's very much appreciated. Dr. Eng, one of our folks said that melatonin gives them nightmares. Do you recommend a way around this at all?
No, so here's someone, I mean, so Samantha, you shouldn't be taking melatonin, I guess. So people that have known side effects already should not take melatonin. So melatonin increases ACE2 levels, so good thing, it doesn't decrease.
Okay, and here's one more really good question, and then I'll let you and Dr. Uhlig say closing words if you would. Last question for now. Children with ADHD and autism who have difficulty sleeping, melatonin is used to help them sleep. Does this mean that they have lower ACE2 levels? Good question.
The other way around. It induces high ACE2 levels, and it's a good thing.
Okay, awesome. Well, did you want to say, Dr. Uhlig and Dr. Eng, a few closing words, and then we'll wrap it up for today?
The only closing word is to wish you and your families all the best, because I know it's really challenging times, and it's challenging for you to change life routine, in particular if there are underlying conditions. So no, just to stay well, and wish you all the best.
Thank you, and you and your family as well. And Dr. Eng?
Yes, hang in there. The whole world is indeed in it together. Follow the guidelines from your respective departments of health, and this too will pass. I mean, for those in the UK, you have heard the Queen's speech. It's only 3 minutes. For those who are not in the UK, even though she's addressing the UK, I think Google search it. I think it's a lovely 3-minute speech, very inspirational.
Awesome. Thank you. Well, we greatly appreciate you guys, and for everyone else, Andrea and I are keeping you all in our prayers, and we will continue to share information as we get it. And just thank you, and everybody take care.
Bye-bye.
Bye.
Thank
See you all in the late summer.
Bye-bye. Bye.
Bye, Christine. Bye, Andrea.